required. Thus, we as a speech language therapist, as a clinician, we can have in one-to-one setup, and with multiple sessions, we can achieve these things systematically. So moving into voice therapy, for voice therapy, major urgent is we need a laryngoscopy will help us to understand the pathophysiology, not just voice therapy. The patient also understand what is happening exactly, and it can be used as a biofeedback tool. Thus, strongly recommending that the clinician to use laryngoscopy as a voice therapy tool. So in our hospital, what is the protocol that we generally follow? In pre-surgery, we either an endoscopy, rigid endoscopy or flexible endoscopy to assess the pre-treatment status, and after the post-surgery, anywhere between second post-operative to fifth post-operative, we do perform a flexible laryngoscopy to assess the status of vocal cords, and then and during that time we assess not only voice as well as the swallowing to initiate if there is any issues with swallowing disorders. And we perform majorly flexible endoscopic evaluation of swallowing in these individuals, as we expect majorly pharyngeal related swallowing disorders. And in follow-up procedures and regular endoscopy is performed. So there are different guidelines available with respect to management, and recent guidelines that talks about the different time points, what has to be done. I'm not going to the major details. So next is the swallowing therapy related to these issues. So generally clinical evaluation that we use is water swallow test and screening test to check for any cough or throat clearing in this patient, and mainly to assess any risk of any silent aspiration, but which cannot be very well understood only with clinical evaluation. Then we move in this patient. Since the patient is having high risk for aspiration, we cannot directly move with 100 ml water swallow test. Rather, we perform a modified water swallow test, wherein which start with 2 ml, proceeding to 5 ml, then with maximum 20 ml to see if any risk. If there is any signs in this issue, then possibly you have to subject the patient to objective evaluation to understand the safety of the swallow and risk of the swallowing. So, and definitely I reiterate again and again that we use these commonly available, very easy to track the outcomes of that as functional oral intake scale with respect to the tube dependency and oral intake, and as well as the normalcy of diet will help all the across the clinicians to understand the patient status. And of course, either we can use video fluoroscopy procedure or the FEES procedure in understanding their safety and aspiration risk of this patient. Majorly, we can go with the FEES procedure in this patient. Okay, I would like to go with a small case example. This patient who underwent total laryngectomy with mild to moderate hoarseness, and after the clinical evaluation, we understood that there was a small post-swallow cough in the modified water swallow test and objective evaluation. I'll play the video of the FEES procedure we have done. As you can clearly see that right vocal cord is mobile, left is fixated with clotic chink, and we have given thin liquid to try. So as you can clearly see that the patient had very mild penetration and was very well managed with just simple post-swallow cough. So that's why this kind of test is very much essential to understand if any of these issues are there, and helps us to take the advice. And the patient was advised to continue to oral diet and with small post-swallow cough strategy, and also we initiated vocal function exercise in these patients. Okay, second example, with the patient had a severe dysphagia post-oral thyroidectomy, and this is a female patient with 53 years old male. We have done the procedure at two different time points, 3 weeks post-op and 8 weeks post-op. I'd like to play a video. As you can clearly understand, there is a severe laryngeal and edema observed with secretion pooling across, and limited glottic gap observed. I'm also waiting for the bolus to come in. Yes, you can see it clearly, thin liquid which his patient has swallowed. After the completion of swallow, there is a clear evident pooling across the vestibule and the posterior pharyngeal space, as well as and spilling over into the larynx, and it is clearly penetrating as well as aspirating, and there is no response to that. So that is the status at the 3 weeks post-op, and helps us take decision whether to initiate orally or not. And next. the same patient after 8 weeks post-op, there is some amount of reduction in the edema as well as the increase in the phonatory gap, which indicates there is some amount of improvement. And we have given the same liquid trial to, as I said, there is some amount of space that can be observed posteriorly. As compared to the third week and eighth week, you can see that there is a reduction in the residue, as well as the patient has some amount of response to that. So with this, we are able to take some decision with respect to initiation of oral diet and what amount of consistency, what amount of quantity the patient can be taken. So last patient that I like present is post-op day 14. We have done the same phase procedure. The patient had reported a severe breathy voice, and you can clearly observe that there is a large phonatory gap observed while phonation task, and we have given as a safety measure. We did not give a thin liquid as a to test on a soft diet only, because we estimated thin liquid as a risk of aspiration. So the advice we have given for this patient to initiate the soft diet and also to initiate 2 spips of thin liquid, and the advice will wait for removal of feeding tube. So one of the most common strategies that is used in these individuals is this Chin-Tuck procedure, which helps to reduce the glottic, improve the glottic closure as well as improve the swallowing. So out of all the other techniques, this Chin-Tuck will be more efficiently can be used in this individual in early acute phase. So one of the study that we have done in a retrospectively, we understood that any patients who have above 55 years, we need to subject the patient into all of these evaluation and in systematic approach. And I'd like to conclude that early voice and the swallowing rehabilitation is essential to improve the functional outcome in these individuals, and FEES is preferred to evaluate the acute pharyngeal phase. We need to initiate voice therapy, and I'd like to also thank you with a small thing that I would like to say, that request is that having a speech therapy can be more beneficial to the team, to the patient, to the institute. I request at least to have one speech therapist who dedicatedly work in onco rehab. So I take this message to the chairperson, sir. Thank you very much. I'd also like to just send a small message that we are going to conduct a national program in tracheostomy course in February 2026. I welcome you all to this program, and the registration has started soon. Please visit our website to register your course, and who are interested, please come to work and attend this course. Thank you.
Thanks to Dr. Rockmathan for your nice presentation. Our next presenter is Dr. Siddharth Shah. Your topic is remote access thyroid surgery. I welcome to Dr. Siddharth Shah for your presentation.
Thank you. Oh, I think I am going to, yeah, laptop. So after all exciting sessions for the day, probably this is the last talk of the day, and that's why I suggested that we put it at last, because this is the advances in the way we operate thyroid surgery. And Mehboob from your place is doing this technique, so congratulations to him. Now we know that we deal with this era of increasing cosmesis and more cosmetic needs. There has been refinements in every surgery in GI, in head and neck, everywhere. We do functional endoscopic sinus surgery. We were doing earlier open surgeries in the neck, in the nose. We used to open up for medial maxillectomy, doing lateral rhinotomy incisions and all. Now we have put on endoscopics to do medial maxillectomy, DCR. We do endoscopic ear surgeries as well. We do lot of microlaryngeal surgeries. So we are going more and more of minimal invasive or endoscopic approaches to improve our outcomes, to improve our results, as well as to give more of a cosmetic outcome to the patient. So yes, at the same time, I remember my bosses when I was in PG, when they used to do lateral rhinotomy, it is hardly possible for them to see. It was difficult for us to see what they are doing. Okay, so now when they were doing otology, we don't had side cameras or screen. So whatever the professor would show me, okay, this is the chorda, okay, this is chorda. I don't know what I was seeing. Okay, so now with the help of this endoscope, screens and microscopes, you have a monitor which can be shown and defined that, okay, this is the structure that you have to see, and it becomes easier for training as well. So this new advent of endoscopes and has really improved the training of the students, and that's a really boon for the teacher, students. So for otology, rhinology and laryngology, we have accepted minimal invasive or minimal access approaches. We use functional endoscopic sinus surgery, endoscopic otological surgery, as well as MLS surgeries. But for neck, endoscope is a real challenge. The reason, all the other structures, they are rigid structures. There is no space compromise. You have to drill the bone, but the cavity will remain wide. It will not collapse. There are important structures which you can really take care. But for neck, it's a collapsible structure. There is no permanent way that you can keep it up, separated. The skins will keep fall. At the same time, the space available between the structures, the skin and the soft tissue, is very minimal. You have vital organs, great vessels in the neck. You have major cranial nerves. You have thyroid, you have larynx. So these are all vital and important structures in the neck, and they are tightly packed. So it was difficult that you can do some minimal invasive or a minimal access surgery in this region. But techniques evolve, strategies evolve, and so with nowadays, probably with more of laparoscopy, that we are doing GI surgeries, gynec surgeries. Similarly, we are able to do neck surgeries using endoscopes. So we know that for thyroid, the definite indication for surgery I am putting, I am not saying, we are not falling into the contraindications of doing thyroid surgery or when not to do, but these are definite indications or reasons that we would be doing. So this was in past in Turkish era, Mughal emperors. But what we do is now do an open thyroid surgery. We open up the neck, remove the thyroid and close the neck completely. So that's what we do practice right now. But what are the limitations? It's an external approach. We have to put a skin cut on the especially a most beautiful area of the body, which is the neck, which is very visible to the eye, and it cannot be covered by any means. Rest of the body part we definitely cover for the rest with our clothes, but the neck is always remaining open. Every individual is a different person. Every individual has a different healing tendency. You may do a best surgery, best closure with the best suture material, but the internal healing or the patient's outcome depends upon the internal healing power. There will be skin edema up and down the flap, skin flap, which will lead to lot of fullness in that region. Patients concern giving how when this edema will going to go down. Patient will have hypoesthesia in that skin area. At the same time, over a period of time, especially in females, the scar line gets shagging down. It keeps on shifting down in the neck, lower neck. So these are the major challenges when we do an open thyroid surgery. So is there any way that we can, for select group of patients, I will just very categorically put select group of patients, where so you can have a very beautiful scar which is hardly seen, and my lot of colleagues do argue what is the need of this remote access thyroid surgery. The scars heal very nicely. There is no need of butchering. These are, yes, very beautiful scar, but there are certain ugly scars also. And this thing is not in our hand because that's an internal healing capacity of the patient, and this, if it is done for a benign condition, probably that is where we will be seeing. So now what is the future? Future of thyroid surgery. You go through a keyhole and remove the thyroid. So what is it, why you want to do, and how you can do it? So here you approach thyroid from a remote location, from an extra cervical region. So you don't open up the neck, but you reach the neck from a different location. So you can use axilla or the chest wall, you can use postauricular region. Dr. Ravi had very nicely demonstrated on the first day retroauricular approach for a neck dissection. So you can use the postauricular approach, you can use the axillary approach, you can use the chest and areolar approach for reaching the neck from all these areas. So you can reach Dhaka from different locations, but you can be in Dhaka from different areas. It's like same. But this ultimately leads to a cut on the skin, somewhere on the body part. It is not visibly located, but somewhere on the skin. And the similar healing issues can happen on that location. So that's why this is not a scarless approach, but it's a remote access approach for a thyroid surgery. It gives an excellent cosmetic neck feeling that there will be no neck scar in the body, but there will be some scar in the body somewhere else. Why you need to do remote access surgery? So majority of our thyroid nodules, they are benign thyroid nodules. We have gone thoroughly through this entire journey of when to operate, what to operate, what not to operate. But we assume that this patient needs a surgery for one or the other reasons, either it's a follicular Bethesda 3 or 4 follicular neoplasm, or for a younger patient who is due for her matrimonial and she needs it for cosmetic reasons. We don't put right now malignancy as the reason. So we commonly see thyroid nodules of around 3 to 4 centimeter in a younger patient. We do get often FNAC as Bethesda 3 or 4 category, and we are helpless what to do. We don't have capacity to undergo molecular testing. And again, the scar is a concerning. So how we do it? There are remote access approaches. So minimizing the scar, you put a very minimal scar of 2 to 3 centimeters and do a video assisted thyroid surgery. You cut that area and you use your sinoscope and do the entire thyroid surgery, the video assisted thyroid surgery. Shifting the scar from where you can shift from the neck to an extra cervical region. So breast areolar approach or bilateral breast areolar approach or into the retroauricular area. Or you do not put any skin scar at all, and that is known as NOTES, Natural Orifice Transluminal Endoscopic Surgery for the thyroid. Here there is no skin cut placed. And this has been the evolution of the remote access thyroid surgeries. Started in 1998 till 2016, there has been a different approaches has been developed. Finally, what is considered as truly scarless is the natural orifice transluminal endoscopic surgery, which is TOETWA. That is what we do is the transoral approach. Because here the incision is nowhere on the skin, it is in the vestibular mucosa, which is the oral cavity mucosa, and we use this natural orifice. We, as an ENT, we use nasal cavity, which is a natural orifice, to perform functional endoscopic sinus surgery, FAST, DCR, skull-based surgeries. We are using that natural orifice. Otologists use natural orifice of external ear to perform endoscopic surgeries. Gynects use natural orifice to perform their lap hysterectomies, even GI surgeons. So these are the natural orifice where you don't have to put any string as an opening. Similarly, oral cavity is a very good, we do tonsil from intraoral, we do stylodectomy from intraoral approach, we do not cut from the neck. Similarly, oral cavity where the vestibular area is the route which we can utilize, perform the neck surgery. We can pass through that region into the neck and perform the surgery and come out from that area. So final incision rests on the mucosal part of the oral cavity and not on the skin, and it will heal within 5 to 7 days very nicely. So ideal case selection for beginning the transoral thyroid surgery is a benign thyroid lesion, approximately 2.5 to 3.5 centimeters of maximum size, benign condition, thyroid cyst, solitary nodule, multinodular goiter can be as you grow your experience, follicular neoplasms, Graves' disease, early papillary CA. As you grow in, this is like as you grow in your experience, you can add on to your basket the number of the category of cases that you can take. But limitation as of now is the nodule size. Up to 5 centimeters or max 6 centimeters with a volume of approximately 45 to 50 cc is the current limitation of performing this surgery. Anything larger or beyond this is the strict no-no for a Toyota approach. So how does it work? The most importantly, otherwise it doesn't need any extra investment. Being in a hospital, multi-speciality hospital, probably you will have a GI department with you, and they already have the laparoscopic system with them, with a gas insufflator, endoscopic system, laparoscopic instruments and everything. These are the same instruments that you would be requiring for your endoscopic approach for the thyroid. Doing a robotic, you need a robotic instrument, that's a different ball and game, but then you can start with laparoscopy. The setup here is you stand on the head end of the patient, the staff entirely is on the head end of the patient and the cart is on the foot end of the patient. And this is how you operate. So in the FAS, you keep the cart on the opposite side and you stand on the side of the patient. Here you stand on the head side of the patient, behind the head of the patient, as you can see here. And the cart is at the near the foot end. So major steps I would say is you start with putting your mucosal incisions, then reaching up to the submental area, try to connect from the oral cavity into the neck, create a subplatysmal tunnel. The way we raise flaps from the open thyroid surgery, we cut the skin, subcutaneous plane and the platysma, and then we start raising superior and inferior flaps subplatysmally. The similar plane is to be achieved from the intraoral approach. We need that area to remain open or widely so that you can maneuver your instrument. So you require CO2 insufflation for this patient with a very minimal pressure of 6 to 8, but a high flow rate, so that because there is an incisions are open, there will be continuous outflow of the CO2 happening. So you need to completely push the CO2 inside. So there will be high flow rate, and the entire surgery of the thyroid is similar to the open thyroid surgery. So most important critical thing is the incision making or marking of this instrument, and this is considered as the safety triangle, the safe triangle in the region between the premolars and the midline frenulum, middle part of the lip is a triangular area which is considered safe to apply your central incision, which is the largest, around 10 millimeters. You need this incision for putting your camera so that it becomes central vision, and the sides you can work with the instrumentation. Now this is the path of the mental nerve, which is the major concern of this surgery, whether you will be damaging this nerve or not. So as you can see, this area, this triangular region is safe to put the incision. There is no nerve fibers which are coming. They emerge between premolar area and then they ascend anteriorly towards the midline. So that path is safe. In between the two nerves, there is a safe path for putting the 10 mm trocar. And the lateral incisions will be between these nerve fibers, this near the angle of mouth, around a centimeter anterior and inferior to the angle of mouth. So these are the locations for the mucosal incision. So this is how you want to create the tunnel. This is the central tunnel, these are the two lateral tunnels for instrumental work, and this is the entire space or the cavity that you would want for the thyroid working space. So we start with this vision, and the ultimate goal is to open up the entire subplatysmal plane, muscle to muscle on either side, sternocleidomastoid to sternocleido, and inferiorly up to the suprasternal notch. This is a short brief video which will explain you this approach. So it was a 45-year female with a Bethesda 5. So it was a suspicious papillary CA. So we start with creating the working space. I have not put the port insertion part just to be quick. So we are exposing the strap muscles and lifting the flap anteriorly. So wherever I am right now working is the foot end of the patient, that is towards the suprasternal notch, and I am coming from the neck oral cavity side of the patient. This is left and this is right side. So right side, left side, and this is the caudal part of the suprasternal area. So I am gradually separating the subplatysmal plane from the strap muscles. These are inferiorly the strap muscles in the base. So once the strap muscles are identified, we divide them in midline. That we will be doing in open as well. We separate them in midline so that we can create the working space of operating. So that's the cricoidal cartilage. Yeah, that's we are using energy device, harmonic scalpel. It is mandatory. Now identify the lobe. You kind of deskeletonize the lobe of the entire strap muscles which are stretched over it, and you try to reach onto the lateral margin of the thyroid gland. Create a space in that lateral gutter so that you can work here. So this is what we are doing right now. So this is the superior thyroid pedicle. That's the superior thyroid, probably vein. So you keep separating, keep lifting it, and try to create a space between the muscle and the nodule. And then you insert a traction suture, which is a lateral door traction, we say, so that in open thyroid surgery, we put a Langen bag to retract the strap muscles. In endoscopic, I don't have, I have only 2 hands to work with. So to help me with the traction, this is a suture which is part from externally and it gets pulled. And so the muscles remain retracted. So now I'm this is the artery, superior pedicle. We take the artery that will free off the superior pedicle of the superior pole. Now this gives you a very beautiful vision of very important even the minor vessels. So these are the parathyroids. This is the parathyroid that I am dissecting. That's the vascular pedicle of the parathyroid. So you do a very good capsular dissection in this region so that your parathyroids get separated inferiorly and they fall back into the thyroid bed. So that's the tubercle of Zuckerkundl, which is our landmark for parathyroid as well as for the recurrent laryngeal nerve. So as I go down, I keep separating the thyroid and the strap muscles and reach toward the lower pole. Now this is the region where you will be finding your nerve. These are the inferior thyroid artery. Just medial to the inferior thyroid artery will be our nerve. This is the nerve which is seen. Okay. So once we have identified the nerve, we know that the nerve is in here, the thyroid is here. We have still ligament of Berry and the isthmus still attached, but I have identified the nerve. I'll just try to separate the nodule laterally. Once I am satisfied the nerve is in the entire length and intact here, we will go towards the midline for doing the isthmectomy. Because we'll come here last part because that will be the only part attached towards the end. So now most patient will have a pyramidalis. It may be smaller in length, it may be larger, but majority of the patient will have pyramidalis. So you always try and look for the pyramidal lobe. Take the pyramidal lobe, just keep following it and you will find the isthmus. So once I separate the isthmus, the thyroid is free from superior, lateral and medial midline attachments, and then I have it easy for me to handle it. So now I am doing isthmectomy, so I am going beyond the midline towards the opposite lobe. Sorry. So that's the midline isthmus joining the nodule. So I am keeping a soft tissue margin or the thyroid margin cuff onto the nodule side. So now that's the Berry's ligament which is keeping and holding the thyroid with the trachea. So I know that my nerve is here. Safeguarding that nerve, I can easily remove the rest of the thyroid which is attached to the ligament of Berry. This is the nerve here, lower down. We need to make sure this is the nerve, this white structure. The harmonic has an active blade and an inactive blade. The white coating is the inactive blade, but the other one is the active blade. So we should try and protect the nerve every time we are using this. Keep the non-active blade towards the nerve. Now this is the bag to retrieve the specimen. We cannot just pull the specimen, otherwise it will get broken somewhere or it may have some tissue left behind in the track. So we always put this in a bag. This is a simple plastic bag. This also ensures that there is nothing left behind. Even if this breaks while removal, the tissue is still within the bag and it doesn't get spilled. So finally, you have to pull the entire specimen out from the same oral central incision that was used for the camera port. So that's the specimen is out. You give a thorough wash, confirm your hemostasis, and we would approximate the strap muscle. Open surgery also we took at least 3-4 stitches in the midline to approximate the strap muscles in midline. Here also the reason is, if we keep this open, once the healing happens, this overlying skin will get tethered to the trachea. That will give some pull effect. So we again approximate the strap muscles. This is barbed wire, the V-lock or the Stratafix that is being used by gynecologists for laparoscopic surgery. So you approximate and the needle comes out from the anterior skin flap. So ensure the hemostasis is done, and this is the final specimen. Similarly, it can be done robotically, the same procedure, same thing with the use of robotic system. I'm not going to go in detail, but you get the benefit of this is the endo-wrist movement of the instrument. You saw the difference between the laparoscopic instrument and the robotic. Here it moves like my wrist, can rotate like my wrist, while the laparoscopic were only vertical instrument movement. So you can see it rotates like my wrist. So that gives more comfort during surgery and more precise removal. Now, so I would like to take a pose. This is the preoperative vestibular mucosal part, and this is the postoperative healed vestibule. You can see hardly make out the difference. This is 1 week, sir. 1 week. So this is the healing that you get after the surgery, and this is the only mucosal cut that were taken in the body. So this technique is considered as truly scarless thyroid surgery. So these are few patients. Finally, nothing is without complications. 1 minute, just last minute. You can have complications related to CO2 insufflation, related to the nerves, related to organ damage, and other like bleeding and hematoma. It's possible. Only thing is, with experience, you try to reduce your complications. I would put remote access thyroid surgery versus open surgery. The only benefit is the cosmesis as of now. There is nothing else that you would rate it. And yeah, it needs a learning curve, but it is doable. Thank you. And finally, I would like to invite you all for our upcoming conference, which is on a recurrent head and neck cancers. Whosoever interested, we have Dr. Vin Paleri, who is master in recurrent head and neck cancer from UK. Hisham Mehana, Mark Zafero. You must have noted certain articles quoted Mark Zafero in the morning, Dr. Shah's presentation. So he has done a lot of work on thyroid recurrent cancers. So they are all going to be part of the conference. So that's on 28th Feb and 1st March. Thank you.
Thanks to Dr. Siddharth Shah for your brilliant and informative presentations. Now, two of our chairperson, one of Dr. Muhammad Ashfaq Hussain, please say something about the session.
Assalamu alaikum. Many thanks to the brilliant presenters for their informative presentation. We have many things learned from their presentations, especially the younger surgeons. Overall thing is preoperative intelligent assessment of a patient with brilliant counseling, hormonal assessment, ultrasonography, and radiological assessment. is very important prior to surgery. Intelligence assessment plus operative assessment is very important for a brilliant surgery. And a brilliant surgery is a very important for a happy postoperative life. Postoperative management will give a very nice postoperative follow-up and a very happy life. We have learned many things from the brilliant presenters, especially younger surgeons, and we, older surgeons, also have gained many things from these lectures. I hope this is a very fruitful session. I give many thanks to all the audience and presenters. Thank you very much.
Thank you for Dr. Ashfaq Hussain sir. Now I am requesting Dr. Ahmed Rakib sir to say something about the session and conclude the session.
Thank you. We are in the thyroid day. It is the third day of this Congress, and we heard in this session some brilliant presentation from the presenters regarding the management of postoperative patients of differentiated thyroid carcinoma. And we heard from the speech and swallowing specialist from Tata Memorial, and we heard from Dr. Saifuddin about the precision and, of using endocrine and management postoperatively. We are definitely benefited from this discussion. We learned many things, and I thank the presenters and the audience for their patience hearing. We are already running short of time, so we are going to the next phase of this presentation, and through this we end this session. Thank you.
Thank you, our distinguished chairperson, moderators and speakers for their invaluable contributions and for sharing their expertise about thyroid cancer with us. Your insights and knowledge have made this Congress truly enriching. I request the honorable sirs to take their respective seats in the audience and enjoy the rest of the session. Now we move on to the deep dive session, and that is the panel discussion. And the topic is From Observation to Operation, the Challenging Landscapes of Thyroid Cancer Care. In this panel, I invite Dr. Siddharth Shah, Professor Dr. Asawari Patil, Dr. Shayak Chaudhary, Professor Dr. Suman Kumar, Professor Dr. A.K.M. Fozlul Bari sir, he was the director of NINMAS, Dr. M. Saifuddin, Associate Professor of DMCH, and Dr. Abdul Karim sir to take on the stage. This session will be moderated by Professor Dr. Muhammad Abdul Sattar sir. I request our honorable sirs to please come on the stage and take their seats. Our moderator, Professor Dr. Muhammad Abdul Sattar sir, is a renowned otolaryngologist and head neck surgeon, working as a professor and divisional head of the head neck surgery division of Bangladesh Medical University. Sir has a vast experience in this respective field and participated many conferences in home and abroad, and also done fellowships, including Memorial Sloan Kettering Center in the New York, USA.
Good afternoon. Slide, please. Today, a lot of discussions on thyroid cancer. We like to moderate on some easy and practical points as a take-home message from our learned moderator and learned participant in this moderation. Our panelists are Professor Ashawari Patil, pathologist, Dr. Shayak Chaudhary, nuclear medicine specialist, Dr. Siddhartho, surgeon, Dr. Saifuddin, our associate professor from Dhaka Medical College, endocrinologist, Professor Fazlul Bari, Director NINMAS, BMU, Dr. Abdul Karim, Muhammad Abdul Karim, our one of the is the organizer of this program. So I am going forward. I am Dr. Abdul Sattar from BMU. So thyroid cancer, a lot of discussions. I will not waste much time. Just in USA, DTC in latest statistics, 14.9% in 1 lakh. This is latest information. So what is in our country? In our country, exact figure is not known. A couple of reasons. Number one, in our country, there is a statistics of cancer registry from National Cancer Institute, where Dr. Karim worked. In these statistics, thyroid cancer has not been included as because after thyroid surgery, we send the patient for radioactive iodine ablation to the nuclear medicine centers, different centers in our country. So in that statistics from Bangladesh government, NICRH, in head and neck cancer has been divided into 3-4 groups. Cumulative figure of that group is one of the top 10 cancer in Bangladesh. This study result from Bangladesh government funded project in BMU. In this we see lip oral cavity top 10 cancer in case of male. In case of female, thyroid cancer is the leading one. So total, if we see total scenario in Bangladesh, male, female, both groups in within top 10. Interesting story is that larynx initial in this study initially that was found number 1. It is this study has been operated in Kishoreganj. Now total number of participants about 4 lakh. Now, if 5 lakhs, this will be country representative. This is going on, this study. So now we are coming to our Hanaken. A slide is not changing. Sorry. Okay. So very easy. I like to share all of you a male of 42 years, thyroid nodule of 1 centimeter, right lobe, mobile, incidentally found, no lymphadenopathy. So workup we have to do. Please, Dr. Siddhartho.
So at such a centimeter thyroid nodule, we should not be digging behind to investigate it further unless there is a strong family history. The patient's family had some thyroid cancer patient, or there is some relevant history in the finding which suggests that this patient might have a early papillary or microcarcinoma. Then only you investigate this 1 centimeter nodule of the thyroid. You can keep the patient on a close follow-up. At the max, you can do a baseline ultrasound neck evaluation just to be sure that future you can have a comparative evaluation of this ultrasound. That's and TSH.
Okay.
Only 2 things.
So this is consensus for all over the world now. If it is like 1 centimeter, we have not to do, just keep it in follow-up. So now Dr. Karim, how long we will follow up this patient?
We usually follow up 6 monthly. We usually follow up 6 monthly. If thyroid TSS level is normal and tumor size is not growing, I think then 1 yearly is possible, this follow-up.
So if this lesion is increasing in size, what is the cutoff point to intervene?
Usually, if 30%, more than 30% is
Okay.
increasing.
So, in guideline has been written, this correct answer, roughly 3 millimeter if increase, time has not been cleared, we can intervene. So now, Dr. Saifuddin, what biochemical investigation we have to do in such cases?
Thank you so much. Thanks, and it's honored to be here. And definitely 1 centimeter thyroid nodule on the white tube, definitely I agree with them that we can keep the patient in follow-up. And regarding thyroid function test, you can just check FT4 TSS, whether the patient is euthyroid or not. But one thing I like to add here, when you palpate a thyroid nodule that is around 1 centimeter, listen to your hands regarding the consistency of the nodule. So I agree with both my previous speakers that we should keep the patient in observation. But if you, I always listen to your hands. If you think this is consistency a bit firm or towards hard, in that case you should details evaluate to exclude the malignancy. Because in our country, a good number of patients, they deposited money, comes to Dhaka, see the investigation, and they will come back to follow up you after 2 or 3 years. So definitely in that case, definitely you should be very cautious not to miss any kind of unusual things. Regarding thyroid function test, only FT4 TSS is, I think, very much okay. Thank you.
Okay, thank you. Now, Professor Fazlul Bari, I like to request, I'm skipping some questions according to specialty. Thyroid scan is necessary in such cases.
Thank you, dear audience, learned audience. Basically, if it is less than 1 centimeter, still we have to do first line investigation, the ultrasonogram, high resolution ultrasonogram, and thyroid is very important. In case of if it is less than 1 centimeter, still we have to see the margin and the consistency, and is there any calcification or not. If microcalcification is present and irregular outline, then we have to proceed for further. We can do the elastography as well as, because you know the 48 to 68% sensitivity for the normal ultrasonography. But whenever we do elastography, we can differentiate whether it is benign or malignant up to 90%. So I think so we can do a high resolution ultrasound as well as elastography with Doppler, and then we go for next planning. Then we do the thyroid scan also. But nowadays, thyroid scan, around 5 to 8% case, 5 to 8% cold nodule can be malignant. But a normal ultrasound is superior than thyroid scan for diagnosis. But thyroid scan is very important for follow-up, post-therapy scan, LDS, and the follow-up. So I think so ultrasound, Doppler, and elastography is superior than the thyroid scan to differentiate
So
any
in
malignancy.
such a scenario, we have not to do thyroid scan initially.
Yes.
Okay. Now I like to request Dr. Shayak Choudhury. Yes. Would you please explain us to do TG, NTDG, or calcitonin in pre-operative scenario in a thyroid nodule cases?
In pre-operative scenario, TG is not recommended usually.
Okay.
And TG also is not recommended.
Okay.
So we will not do calcitonin if there is a index suspicion for like MTC. However, pre-operative calcitonin is also not recommended in most cases without a FNSA suspicion of MTC, or if there is a family history of MTC and a high suspicion of this patient being one of the syndromic.
Is there any possibilities to assess pre-operatively by assessing NTTG for post-operative baseline scenario? Is there any scope?
No, I don't think so. I don't think guidelines also say to do
Okay.
TG and
So
NTTG pre-operative.
TG and NTTG is not recommended pre-operative scenario. About calcitonin in our country, where FNSC report is not uniform all over the country, is it help to predict medullary carcinoma if we do it earlier? we get some help from calcitonin preoperative scenario. So I now request Professor Ashari Patil ma'am you have said a lot during your talk. So to crystallize this, what is the impact of FNSE? What are the indications in this scenario, and what are the findings, interpretation?
So I can say this is 1 centimeter mobile incidentally detected nodule, and FNSE will not be done unless and until this is radiologically suspicious, or there is any family history of, or there is any radiation history. I'm sure Dr. Suman can always throw more light on that. But if at all the patient fits in any of this category, any clinical suspicion or any radiological suspicion, so FNSE may be done on this one.
Okay. So less than 1 centimeter, we have not to do, just keep this follow-up. Okay. If more than this size, what would you do? And you already talked, but we like to know.
Again, more than this size means just 1.1. I'm sure clinicians will, because actually that was decided by the radiologist and the clinician. They will take a call. Most of the times it's clinical suspicion. Size is one important, but clinical suspicion and radiology suspicion is more important in that case.
In Tyre's recommendation, there is 2.5, something like that recommended.
So that's the thing.
But in ATA, we see that this is 1 centimeter, something like that. So how will you?
So again, I think what I would suggest Dr. Siddharth or Dr. Karim to take this question, and again Suman also. But I think these are the gray zone areas, and that every clinician or radiologist will take a decision based on their findings.
Okay.
ATA guidelines says 1.5 centimeters, but latest ACR guidelines, they have found out that if it is more than 2.5 centimeters,
yes.
if it is a TIRADS 3 lesion, then you can do FNSE.
Okay.
And if it is a TIRADS 4 lesion,
yes.
then it should be more than 1.5 centimeters.
So we have to correlate with previous ultrasound findings and others.
Yes.
Thank you. So I like to request Dr. Shumon, he's from radiology, importance of cross-sectional imaging like CT, MRI in this scenario, or a bit advanced stage, just for discussion.
So the nodule size and location is also very important. If it is located posteriorly or if it is located close to the trachea, then you would want to see if there is an extrathyroid extension or not. And if there is an extrathyroid extension on ultrasound, then the chances of central compartment nodal involvement is also high. So the size, location, and the nodal status. And then if at all, if you are not able to assess the central compartment on ultrasound, then cross-sectional imaging is required, like a CT scan of a neck and thorax, just to assess the central compartment nodes when you are contemplating extrathyroid extension and infiltration of the trachea.
What are the level of lymph nodes? Usually not confidently comment that this is present or not. What are those levels? Would you please clear us?
Normally the spread is towards the lateral compartment. Those level 4 and level 3 are the first nodes to be involved. And if it is located medially, then the chances of a central compartment node, level 6 nodes will be involved. And the size criteria, according to the guidelines, is 8 to 10 mm. But irrespective of the size, if they have microcalcification, if they have lost their architecture and they become rounded, then we call it as a suspicious node, and FNSE is recommended for those nodes.
Okay, thank you. So, ma'am, again, your talk was on genetic testing. When will you recommend for genetic testing?
So, genetic testing in these cases, unless and until you have FNSE, say Bethesda 3, TRBTC 3 or 4, or sometimes 5, then and then only, and that will be molecular testing actually.
Molecular testing.
Molecular testing. But again, in our countries, most of the times we will tell you what it is. AUS, if we say Bethesda 3, you may want to go for the molecular testing unless and until if you have any clinical suspicion of like high probability of carcinoma. If there is no high probability of cancer, I think the clinicians can take, or surgeons can take their call.
Just other than diagnosing, what we can get benefit from this molecular testing?
So molecular testing in thyroid tumors, we can say two broad categories. One is diagnosis, as we said earlier, which is based on FNSE and in particular categories. Second is when we call frankly malignant and larger tumors, or sometimes we say poorly differentiated anaplastic. Definitely it has a place to find out the actionable mutations for targeted therapy. So there again molecular testing for therapeutic decision is required.
Okay. Question to next one. What are the importance of, in this scenario, there is a recommendation from ATA 25, recommendation 11. We may observe or we may some sort of percutaneous ablation. So, role of percutaneous ablation.
So I don't think I am the right person to take this question.
Okay, Professor Bari. Okay, please.
Percutaneous ablation is, there is no strong recommendation for percutaneous ablation.
This is low certainty evidence, conditional
yeah,
recommendation.
Conditional recommendation, yeah. That's what is the recommendation. Only if the patient is apprehensive and then he doesn't want to undergo a surgery and he wants to get it removed, then you can offer a percutaneous ablation, and the chance of recurrence and regrowth rate is less than 5%, and then complications rate is also low. So it can be offered only if the patient is apprehensive about that surgery and doesn't want to keep the nodule.
Okay, this is very right.
I think
okay,
we just
please.
Make a strong message is, as of now, even the intervention radiologists, they fear or maybe they refrain from ablating a PTC or a malignant lesion.
Yes.
The reason is it's still a very emerging specialty or the technique. We don't have long-term follow-ups available in this. It's just almost 4 or 5 years old technique. And there are so much, as of now, whatever studies they have been done or papers have come out, they have suggested that or shown that after around 3 years, the nodule grows resizing. I mean, it starts regrowing. So unless they are sure that this is going to be a benign nodule, they are not going to take up the patient for ablation.
Okay.
Not even Bethesda 3 or 4. So if it is Bethesda 2, they will be ablating. So I think that should be the message conveyed, that because ablation is a technique, new modality coming up in terms of avoiding the major surgery. As of now, there is a strong case selection of only benign lesions.
Okay. So we get the message. Okay, please.
So the role of ablation in this case is just cosmesis, is it?
Yes, that's only cosmetic. So avoiding a major surgery, avoid jeopardizing the nerve and parathyroids like that.
Okay. So
I want to add something.
Okay, please.
Radioiodine ablation now is very good method.
No.
This was RF ablation.
Percutaneous.
Radio frequency ablation. In Korean Thyroidology and Radiology Society have a guideline. We can do radio ablation benign as well as the small cancer, papillary, micropapillary cancer also. If it is oil outline and sonographically it is 3 or 4, we can do it. And
Okay.
at the same time, we can do all benign lesions.
So message is not to recommend. And interesting story is, after recommendation, there is a discussion on recommendation 11. In this para, they strongly discourage to do it and tell that if you do that, before that, discuss with patient that subsequent surgery will be difficult. Okay. Now we come to again Dr. Karim. Size has been increased now, 3 or 4 centimeter.
Okay.
What will you do?
Okay. Usually recommendation is if more than 1.5 centimeter, then we will do fine needle aspiration cytology. If less than 1.5 centimeter, but Tidus 4 or 5, then we will do fine needle aspiration cytology. But size is increasing. Now its size is almost 4, but benign. Then in case of benign, when you offer this patient for surgery, number 1, cosmetic purpose. Number 2, any compressive symptoms.
What will be the size? usual size? No comprehensive symptoms and others. What will be the standard size to offer him or her surgery?
Surgery. Usually more than 4 centimeter will offer him surgery because chance of malignant.
In case of benign.
In case of benign.
So in case of malignant?
In case of malignant, usually less than 1 centimeter we active surveillance, and more than 1 to 4 centimeter will do. If size criteria and no extrathyroidal extension, then we will do hemithyroidectomy.
Okay. So when will you offer total thyroidectomy?
Extrathyroidal extension patient, lymph node metastasis, or
Multifocality?
And
Multifocality?
Definitely multifocality.
Multilobe?
Multicentric.
Multicentric, multilobe.
Multicentric, then we will offer him. Or age less than 15 or more than 55. Size more than 4 centimeter.
4 centimeter.
Extrathyroidal extension. And also aggressive histology.
Aggressive histology. Okay.
Please. See central compartment nodes on both the sides, even though there is no structurally identified disease on the opposite lobe, you will still contemplate total thyroidectomy.
Okay. So, next I'd like to ask a question, Dr. Saifuddin. What assessment will you offer after thyroid surgery for endocrine perspective? You already, I already said, but
yes, sir. Regarding radiofrequency ablation, I like to add just one point. As this is a critical decision, as this is I already mentioned, this is a newly emerging techniques and a specialty. Not so many papers have been published. So in that case, discussion with the patient regarding these things is having what the patient recommend or suggest for you. This is a shared decision between the clinician and the patient, definitely. Regarding surgery after total thyroidectomy, definitely thyroid function should be checked. And there is one fear of the hypoparathyroidism, whether it's developed or not. Calcium, magnesium, and thyroid function test.
Okay. With reference to your previous talk, I would like to support you in recommendation in ATF 25. There is some discussion on empirically to give calcium and Realitrol or
definitely. In our setting, if you consider other than few good ENT hospitals where the practices, other than this institute, in the most of the times, IPTH comes maybe 2 to 3 days later, and also the quality of test is the one of the important thing. Outside Dhaka, this kind of tests are not available. They will send it to Dhaka, they will come after 7 days. So empirical, I suggest, it's my suggestion to ENT consultant, just don't afraid of adding empirical calcium and vitamin D. After 1 or 2 weeks, depending upon the calcium level symptoms, you can discontinue definitely, and you can take help from endocrinologist also.
Is there any tool to assess or to predict hypocalcemia day 1 after surgery?
Predict whether the patient has any symptoms, and number 1. Number 2, I always suggest...
before appearing symptom.
Yes, I always suggest ENT surgeon to check the blood pressure by himself. Definitely, this is a good tool by checking whether the patient have any tingling, numbness, or any kind of titanium vortex, and these are the good things. So whenever ENT consultant I meet after especially total thyroidectomy or parathyroid surgery, I always request the consultant, when you visit your patient, say for once a day, just check the blood sugar by yourself. Ask the patient about the symptom, check blood sugar, not by the duty doctor, by yourself. Then you can detect a bit early or whether the patient has developed hypocalcemia.
Is there any role of assessing parathyroid hormone before surgery that compare with after surgery, day 1 or like that?
Especially in thyroid cancer patient, usually that is not indicated to check parathyroid hormone before surgery. Definitely, there is no need. Unless there is evidence, CT or imaging indicate that there is a associated involvement of the parathyroid. Otherwise, there is no indication.
There are some papers, not here, there are some papers, if it drops by 1/3 with previous one, day 1.
You can definitely, but in our settings, and I think this will add more expense to the patient.
Okay.
In fact, I usually don't practice checking parathyroid hormone before total thyroid surgery.
Okay.
But if the patient is affordable, patient convinced, patient stated to you, I like to check, I am very concerned. Some of the patient has gone through internet a lot, and they find, be careful about my calcium and IPTS. In that case, I suggest, okay, check baseline calcium, albumin, IPTS, and magnesium. After 1 day, we'll check again to be compliant.
Dr. Gorim, will you add something?
I add one thing. Just like this operation, total thyroidectomy done by high volume surgeon.
Will you qualify high volume surgeon?
More than 100, okay, more than 100 thyroid surgery in year.
Okay, anybody?
So there was.
Okay.
So,
I utilize at something in 88-15. It was 100, more than 100 per year. In 88-25, 25 to 50, 50 per year. This has been clearly written.
There is a paper by Duke Health System.
Okay.
It's a French system who assesses the efficacy of this thing. So they have graded how many is considered as high volume. So less than 25 is low volume. About 25 they are considered as high volume. So at more than 25 thyroid surgeries a year is considered as a high volume.
Correct.
Then you are a high volume surgeon. Then you have done total thyroidectomy. Then not empirically calcium and dicalcium such like things. You just advise in recovery room, parathyroid hormone and serum calcium. Then decision accordingly.
Okay.
One thing I just read, according to American Association of Clinical Endocrinologists, who has done more than 40 thyroid surgery per year, is known as high volume thyroid surgeon, and endocrinologists are advised to send such type of surgeon to any kind of thyroid surgery. So in our country, in front of my eyes, I saw no one is no volume, because there are lots of surgery they are doing. Maybe 181 is high volume surgeon, I think.
So some small questions to surgeons also, please. শেষ করে আসুক। Operatively, what important points you have to be very cautious to save recurrent genital nerve and parathyroid in our scenario, like where neuromonitoring and autofluorescence not available?
Yeah. So yes, very importantly, you have to clinically be confident about, or you have to clinically judge that your nerve is functional. Nerve monitor and everything has come just recently. Autofluorescence also has come recently. Now autofluorescence helps you to identify, it cannot prevent. It can just tell you that the
not to see blood supply also.
Yeah, it cannot see unless you put an ICG and then you trace the vascular supply and then you prevent. But otherwise autofluorescence.
So these tools are too costly for our scenario.
Agreed. So this becomes helpful in recurrent cases where you want to locate, or when a thyroid malignancy central compartment nodes are extensive, you want to identify which one is parathyroid so that you can safeguard. So autofluorescence will help you there. Otherwise you need
Have you any suggestions for juniors how to save nerve, especially operatively?
So the most important thing is you have to go capsular dissection.
Capsular dissection.
So once you do the capsular dissection, your parathyroids are safely preserved, and you identify your tubercle of Zuckerkandl, which is the most constant landmark for your nerve.
Very important point.
So once you identify your Zuckerkandl, just underneath it, between the thyroid, ITA, that is inferior thyroid artery, medial to that you will have your nerve.
Okay.
There is lot of stress of finding the nerve during surgery. I would recommend not to hunt for the nerve. If you stick to your steps, automatically you will discover your nerve.
Okay.
So because people start digging in that TO groove to identify the nerve, and that creates some praxia, neural injury to that nerve. So if you stick to the thyroid, stick to the capsular dissection, and go slowly hugging to the thyroid gland, you will invariably find the nerve in the TO groove underneath the tubercle of Zuckerkandl. So I will just say that don't try to dissect it out. If you are, and it is important that you don't dissect the nerve in the entire length also.
Okay.
If you have identified the part of the nerve, just leave it, because the capsule of that nerve, the fascia covering the nerve, will have the vascular supply for the nerve. So if you try to delineate the entire course, you are damaging the vascular supply of the nerve. So you should be very sure that, okay, this is the nerve, and thus you have to stay medial to it and superior to it.
Okay. So I like to ask Dr. Karim, do you like to add anything, or I like to?
I like to, sir, add one thing. In case of superior pedicle,
yes,
we usually clamp.
Yes.
Blindly. We usually clamp blindly all vessels, and I think there is parathyroid gland also. I think it should be ligated separately. And many time there is no ligation required in superior parathyroid gland. If you do it capsular discharge.
Okay, Karim, 1 second. I like to add one word in ATA 15 and 25. Both mentioned that recurrent laryngeal nerve should be identified and external branch of superior laryngeal nerve may be identified. These two words are different. Okay, so I like to request, time is running, I like to request Dr. Karim, which patient will you refer to Professor Bari in NINMAS for radioactive iodine ablation?
Today we have lots of discussion regarding this.
Just in brief.
In case of low risk cancer,
we should not do.
Never. Usually
and high risk we should do. We should set.
Never. Usually in my practice I never refer this patient in NINMAS. But if you refer this patient in NINMAS, I think every patient get some sorts of radioiodine ablation. But radioiodine ablation is highly recommended in certain cases, and today's lecture Professor Ashok Shah also said in differentiated thyroid cancer day by day radioiodine ablation is less importance. Okay, thank you.
Dr. Shiddu, would you like to add anything?
I think in my practice, I do consult the nuclear medicine guy just to be on a similar page that we discuss out the case, whether this patient needs any evaluation also or just an evaluation and no therapy. So that in future coming times, he is aware about the case. So in that terms, we do send this patient for evaluation by the nuclear medicine people so that they are aware about the thing and they can guide us about how or when we should kind of intervene. So from the level, so once we operate, we keep the patient off thyroid supplements, measure TG, anti-TG at the baseline. The TG value will guide you whether you will need to do any further evaluation.
Any points of high risk, like fixed tissue or extend up to the strap muscle and others, would you say?
Sir, we are talking about low risk patients where we do need to investigate or evaluate on. So high risk, there is no query
No
about,
question.
there is no question about it.
Okay. So,
Just to piggyback on Dr. Siddharth, in the current ATA guideline, they have this data system, right? Like you do something, then you assess. So previously, the initial assessment would be typically after surgery and radioiodine therapy. But now they are saying that even after surgery, you assess it.
Yeah.
So assessment would be typically by TG. So now there is levels for everything. For all levels of what type of surgery you are doing, TG levels are there. And even for lobectomy also, there is no TG level, but they have given guidelines for what can be constituted as a complete response or what can be constituted as a structural incomplete response.
Okay.
So based on the assessment, if this is an excellent response, then intermediate risk, I think you can still go ahead that keep the radioiodine for on hold for now.
So there is a dynamic risk stratification, what he had said.
Yes.
So every follow-up you have to re-evaluate the patient and put it under that risk stratification. You do ultrasound, you do biochemical evaluation.
We are coming that point. Now I like to request Professor Bari, patient sent to you, high risk and intermediate risk some. So what will you do? What are you doing? Let us know.
Patient referred to us for radioiodine surgery, then we wait for 2 to 3 weeks nowadays, and then we do some baseline investigations like the TG.
What are those? What are those? What investigations will you do?
Yes, then we do the TSS and FT4, and then TG, very important, you know already, you heard from everybody, and mostly we depends on also histopathology report.
You will not do anti-TG?
Yes, TG.
So tumor marker is TG.
Yes.
What is the role of anti-TG and TSH?
We do also anti-TG because whatever is there any chronic changes in the tissue, then maybe cancerous. That's why we also do the anti-TPO antibody and the anti-TG also. And then we also depend on the histopathology report because we have to see the cancer tissue invade the margin or the already invading and neovascularization crossing the margin, if the histopathologist mentioned, then it is easier for us to calculate the dose as well as for the decision. So I think so.
Okay, Dr. Shai, could you add something?
So in our institute also, after most of the time patients are referred after 3 to 4, by the 3 to 4 weeks mark, we'll do TG, anti-TG, serum calcium, TSH. We normally don't do FT4 because at the time I think it doesn't add much clinical value to us. Anti-TG we do for all patients. You cannot evaluate a TG value without anti-TG. The immunometric as previously when we used to do RIA, radioimmunoassay, with radioimmunoassay there was anti-TG interference much less. However, the current immunometric assays like chemiluminescence, CIMA, CELA, it has heavy anti-TG interference.
Okay.
So
In your institution, what dose you offer that patient? Your institution?
For treatment.
For treatment.
So that depends. So remnant ablation we are hardly ever do now because low
average
patients are not
100 to 200.
No, if at all I have to do remnant ablation, I would give 30 millicurie, not more than that.
Okay.
This was there was a long time back. There was a study done by Dr. Bal in AIIMS, New Delhi. So he had periodically given some higher dose of activity like 15 millicurie, 20 millicurie, 30 millicurie, up to 100 millicurie he went, and he saw that the remnant ablation success rate that is happening in 100 millicurie is same as what is happening in 30 millicurie.
Yes, very correctly that has been mentioned in the ATA guidelines.
ATA guidelines as well.
So I'd like to request another question for Dr. Bari. In our country, what is your practice regarding dosing of radioactive iodine ablation?
Radioactive ablation. In our country, we have the starting dose we start from 30 millicurie and up to 150 if metastasis present, and is there any only local metastasis or the cancer variant, whether it is papillary or follicular, and is there any distal or lungs metastasis. We use the variable doses, we calculate extension of the disease, histopathological report, and the site of metastasis.
Dr. Siddharth, would you like to add something?
No, I have to ask them too. Say your post-operatively anti-TG is higher than normal, 50.
Yes.
And your TG is around 10. Now, whether do you consider significant or how will
we are coming to that point. Yes, later. We like to go to sequentially. A lot of our students and junior colleagues are here, so we have to go to sequentially. So radioactive iodine ablation is done. Please.
So in our institute, like for adjuvant therapy, where like in high intermediate or high risk patient where there is no other distant metastasis, the tumor is R0 resection, R0 probably R1 resection. So there adjuvant therapy, normally we give 100 millicurie.
Okay.
So we don't usually, maybe 100, 120 millicurie depending on how much activity we are getting. For metastatic patients only we go up to 150 to 200. For lung metastasis maybe a bit less, but bone metastasis we will give till 200 millicurie.
I like to ask
that means we want to go a consensus. In low risk thyroid cancer, we will not require any radioiodine ablation.
Okay.
But is there any comments, sir, from your side?
No, this is decided.
I just like to add one point. In our country, irrespective of differential, irrespective of the grade, all the patients are getting radioactive iodine. This will never found in any developed country.
This is not correct.
But
in our country, we are sending only intermediate risk and low risk. And previous director
but what happens? Patient comes to separately. Abdul Karim Mitu sir told there is no need of radioiodine. So what's your opinion?
We have to ventilate this information today that all patients should not get radioactive iodine ablation.
Yes, I think a good number of patients who are not candidate for radioactive iodine are getting radioactive iodine. Patient comes to separately to ENT consultant, endocrinologist and nuclear medicine specialist. If any one of them says it's better to give it, patient will give it. So we should make a separate consensus statement, consist of ENT consultant, nuclear medicine specialist and endocrinologist, that what kind of patient should get radioiodine in our setting.
Yes.
Until we publish our own consensus, otherwise there the discrepancy That's what going on. It is continue to go on. Thank
Now
you.
I like to ask ma'am to tell us, radioactive iodine have been given. It is recurring. Oh, another question I like to ask both of you, nuclear medicine specialists. Average, how many patients are radioactive iodine avid? Average, as a whole, all thyroid patient.
So the DTC patient that we get in our clinic, so depends on, now it is bit variable depending on histology and all, but on an average more than 85 to 90%.
85, this is a bit higher you are telling? Probably.
But I am obviously excluding the poorly differentiated.
There is a reference in ATI guideline 25. They told that please. There is a comment on ATI guideline 25. Roughly 60% patients are radioactive iodine avid, those who are thyroid malignancy with metastasis, and 1/3 of them are resolved with repeated radioactive iodine treatment. This has been written in this.
So the thing is that that I was not taking only the metastatic disease.
Yes.
I was taking the patients whom we think that they are radioactive avid because of there is a remnant.
Okay.
Okay, so I was counting those patients as well, because we are treating those patients thinking adjuvant therapy.
Okay.
And based on there is some remnant, we are saying that this patient probably would have gotten the treatment. So if we include those patients, just not the metastatic patient, I'm talking about the patient who have been operated and now only the neck bed uptake. So if we take that into account, it is pretty.
Okay. Small question. What are the patient good candidate for radioactive iodine ablation? Small question. What are the patient?
We have a study in NINMAS last 5 years. The low risk patient, because I think so is the initial information for the ENT head neck specialist. And we have around 250 patients, and after one group we give the radioiodine, and another group just follow up every 6 month follow up. Then 97.2% of that patient we got no significant difference. So I think so it's information for us, and only around 2.5% patient have the recurrence.
Okay, ma'am, I like to ask you what genetic backup compelled to recurring the cancer?
I didn't understand. I mean,
what genetic backup, established genetic backup compelled to recurring the thyroid cancer?
well, I think genetically. So actually, that is not something like any molecular test can define which one
Like
will recur
RAS,
or. Yeah.
RAS and RET,
So that's the thing.
BRAF and others.
So BRAF have definitely worse outcome, BRAF positive papillary thyroid carcinoma. But otherwise, it's like there is not a single other molecular test that can tell you which one will.
Anybody
become.
supplement anything for this question? Why recurring after ablation? What genetic backup?
So,
I don't think so. It is difficult to predict, but there are like the whole ATI stratification is the that is what that we can use as a template, like which tumors have.
So everything is dependent on all the risk categories.
What genetic backup? Question is what genetic backup? BRAF positive, others? Written here, RAS and RET is good candidate for ablation.
Yeah, no, RAS and RET, actually RAS is kind of like follicular pattern tumors, so follicular carcinoma, thyroid carcinoma, they are there. But papillary, again there are differentiated tumors, they are good. And tall cell and other variants, some Hobnell variants, they are aggressive. But then if you look at the risk categories, it's not only the genetic. They don't include that much. It is the type of the tumor, number of vascular emboli, extrathyroidal extension, number of nodes. That is more important, I think.
Okay, thank you. Now I'd like to ask Dr. Shumon. After recurring TG is rising and anti-TG is normal range. So what imaging will you suggest to check this situation?
Again, I'll start with the ultrasound of neck.
Yeah.
And if at all, if there is any definite evidence of a nodule or a recurrent or residual node, then that would be the cause of TG levels. And if there is no suspicious node or recurrent nodule in the thyroid bed, then I would ask for a CT scan evaluation of thorax to look for any metastatic lung nodules.
Okay. So time is short. Can I keep some discussion on medullary thyroid carcinoma? This is very much.
Sir, Sattar sir, one question from the audience to Dr. Saifuddin. If after total thyroidectomy, if in what basis our doctors will prescribe calcium supplement? It is the serum calcium level, or it is the patient symptom, or combination? And if it is serum calcium level, what is the cutoff? What is the cutoff? In which level the patient we will prescribe calcium supplement, or is the only symptom?
Definitely, it depends upon the combination. Your clinical judgment and rep report, both are important. Definitely serum calcium, magnesium, albumin. Also, if you have ability or if you have facility to do an IPTS, and also clinical assessment. Depending upon all of these things, you can suggest calcium and vitamin D.
Calcium level is 6, patient is not symptomatic.
No, still you should suggest, because when biochemical is so still may symptom, but patient may not be symptomatic at this moment, but you don't know when the patient will go home, say for 400 to 500 kilometers from here. Definitely in that case, you should suggest.
I like to conclude by showing 3 pictures that are in thyroid. This is external metastasis. We have done this patient. Professor Rajiv was shown this case. Thyroid lesion was microcarcinoma. Another case, these 3 patients we have treated previous month. Another patient also total intrathoracic and microcarcinoma. Another patient with metastasis sternum and microcarcinoma. So microcarcinoma not always safe. We have to keep a good look on that cases. So I like to conclude the session after.
Just one comment. According to WHO 2022 classification, now the microcarcinoma comment is out. We know that up to 1 centimeter we used to call it, but now we have to specify what type of carcinoma it is, because if it is aggressive histology or other parameters are there, it is no more microcarcinoma. So we are not reporting any as microcarcinoma. We'll say it is papillary thyroid carcinoma less than 1 centimeter size or so on.
Sir, at the diagnosis was multinodular goiter preoperatively, your case, sir? Your case diagnosed was multinodular goiter, retroexternal extension, sir?
Yes.
Multinodular goiter, retroexternal extension.
No, there was only 1 centimeter lesion in thyroid.
Okay.
We did not do this FNSC. In thorax, there is a big lesion, and that was papillary microcarcinoma.
That means.
So this may happen. We have to keep in mind. Reality, but this, yes.
He has shown indolent character in case of low risk micropapillary carcinoma. But if a micropapillary carcinoma, what this guy has told, if it close to recurrent navi, if it invades, trachea, if it is a high variety, high risk variety, these are all high risk varieties. So this can metastasize even.
Sir, so Sattar sir. I want to share with very much important things with you. In my combat military hospital, one of our officers lady, she was 40 years old lady. She was limping with her shoulder problem. She was repeatedly visiting the shoulder problem physiotherapy department. Unfortunately, nothing solution was given to her. Incidentally, she got a thyroid nodule. Incidentally, I did a FNA. It comes papillary thyroid cancer. Then I have done surgery, and because this scenario repeatedly we are getting.
Okay.
1 centimeter nodule paraoperatively, if you get a single node in the central compartment, it is high risk.
We get the point.
So,
In our country, in our country, thyroid cancer management has been paradigm shifted to general surgery to ENT. So I like to all our ENT colleagues to get more academic knowledge and expertise on this subject. I request all of you. Number one. Number two, medullary thyroid carcinoma and aplastic carcinoma, some sort of discussion is there today also. But no medullary carcinoma today, full day. So I like to request all of us to practice on it, to just give a look on this scenario. This has been taken from a standard book. So easily you can diagnose this. Just keep in mind serum calcitonin. So though it has not been recommended in many books, I like to request do a small investigation like serum calcitonin, you will get it. Thank you very much.
Sir, one small announcement.
Yes, please.
Yeah, there is a thyroid preceptorship program that happens in Tata Memorial Hospital every year. So if you are interested, then it's a 7-day workshop with surgery and pathology and radiology program. So if anybody is interested. So if anybody is interested, then you can always apply and then attend it.
Okay, thank you very much. Thank you everyone.
এখন আমাদের একটা এক্সাইটিং সেশন আছে, প্লিজ জাস্ট 10 মিনিট, যেটা হলো আমাদের কুইজ কম্পিটিশন। সাত্তার স্যার থাকেন এখানে, সাত্তার স্যার হানি স্যার দুজনে থাকেন।
Thank you respected panelists and the moderator sir for enlightening us exploring new ATA guideline and treatment strategies of the thyroid cancer. I humbly request our honorable sirs to take their seats in the audience and be with us in the next part of the session. Now it's quiz time. Get ready, think fast, and let the challenge begin.
Hanif sir, please come to dais.
Everyone, it's quiz time.
Okay, yes. Thank you. না আপনি বসেন, একটু জাস্ট কুইজ কম্পিটিশন।
Dr. Mahbubul Haq sir and Dr. Nasib Muhammad Ishadullah sir, please come on the stage and conduct the quiz session.
Respected chairperson, panel expert, my dear teachers and colleagues, assalamu alaikum. Welcome to you all to this quiz competition. I would like to request our sir, Dr. Najib Muhammad Ishadullah sir, Associate Professor, Department of Hematology, National Institute of ENT, to start the session. যারা গতদিন কুইজে অংশগ্রহণ করেছেন তারা তো রেজিস্ট্রেশন করেছেন, আজকে নতুন করে রেজিস্ট্রেশনের প্রয়োজন নাই, শুধু কিউআর কোড স্ক্যান করে আপনারা মোবাইলে কোশ্চেন দেখতে পাবেন। আবার একটু রিমাইন্ডার দিচ্ছি, 5টা কোশ্চেন থাকবে, 5টা কোশ্চেনে প্রতিটা কোশ্চেনে 1000 পয়েন্ট
PowerPoint
থাকবে।
is not showing that.
1000 পয়েন্ট থাকবে, যে যত দ্রুত আনসার করতে পারবে তার পয়েন্টস তত বেশি বাড়বে। ধন্যবাদ। আজকের টপিক হচ্ছে থাইরয়েড ক্যান্সার বা থাইরয়েড। কিউআর কোড যারা স্ক্যান করেন নাই করে নেন।
আসসালামু আলাইকুম। হ্যাঁ, ধন্যবাদ।
স্ক্যান করা শেষ? আমরা কি নেক্সট স্লাইডে যাব? না না,
নাম দেবেন, যারা আগে কখনো রেজিস্ট্রেশন করেন নাই পুরো নাম দিয়ে
রেজিস্ট্রেশন করবেন।
প্রসিড করবেন, তাহলে রেজিস্ট্রেশন হয়ে যাবে।
স্টার্ট করেন, নেক্সট স্লাইড।
আমরা প্রশ্নে যাচ্ছি।
জি স্টার্ট।
শুরু করছি আমরা।
কোশ্চেনটা পরে মনে রাখতে হবে, নেক্সট স্লাইডে কোশ্চেন থাকবে না, শুধু আনসার থাকবে। নেক্সট স্লাইডে যাবো।
সময় শেষ, আমরা ফলাফল দেখি। প্রায় সবাই সঠিক উত্তর দিয়েছেন। পরের প্রশ্নে যাচ্ছি। আমরা উত্তরে যাচ্ছি।
সময় শেষ।
লগইন না বলি তো মুখে বলতে।
আপনি ওদিকে খেয়াল করেন।
পরের প্রশ্নে যাচ্ছি।
লম্বা কোশ্চেন, একটু সময় নিয়ে পড়েন। চুপচাপ দেখেন, কথা বলে দেখেন। নেক্সট স্লাইডে যাবো। সবার কি পড়া শেষ? নেক্সট নেক্সট।
আমরা ফলাফল দেখি। এরকম হলে আমরা হয়তো একটু কনফিউজড হব।
না, নেক্সট নেক্সট স্লাইড যান, নেক্সট স্লাইড যান। নেক্সট। সমস্যা নেই। নেক্সট স্লাইডে যাবো।
আমরা অপশনগুলো দেখি। সঠিক উত্তর পরের প্রশ্ন।
নেক্সট স্লাইডে যাব। নেক্সট স্লাইডে গেলাম।
না সবাই হয়েছে কিনা
অন্যদিকে থাকেন। I'd like to request our director sir, Professor Dr. Mohammad Hassan Jabbar sir, to come to the dais and join us to in prize giving ceremony.
আমরা সঠিক উত্তরটা দেখি। এখন ফলাফল ফার্স্ট সেকেন্ড থার্ড যারা হবেন তারা মোবাইল নিয়ে সামনে চলে আসবেন, স্ক্রিনটা অফ করবেন না।
সবাই যারা ফার্স্ট সেকেন্ড থার্ড হয়েছেন তাদের জন্য জোরে একটা হাততালি। আসেন।
চরম প্রতিদ্বন্দ্বিতা, 3782 দুইজন পাবেন এটা আশা করা যায়নি, তবে দুঃখজনকভাবে কেউই সবগুলো সঠিক উত্তর দিতে পারেননি।
আমরা ওই স্ক্রিনে যে ফার্স্ট হয়েছে তাকে আমরা প্রথম পুরস্কার দেব। প্রথম হয়েছেন ডক্টর বিজয় সেন, দ্বিতীয় হয়েছেন মোহাম্মদ আলী মিতুল, থার্ড হয়েছেন ডক্টর মোহাম্মদ শাহ সেকান্দার তুহিন। সবাইকে স্টেজে আসার জন্য আমন্ত্রণ জানাচ্ছি। প্রথম তৃতীয় পুরস্কার নেবেন, তৃতীয় থার্ড পুরস্কার
না, থার্ড আগে আসেন। থার্ড
জি ডক্টর শাহ সেকান্দার তুহিন ভাইকে থার্ড স্যার ফজলুল ভাই স্যারের কাছ থেকে পুরস্কার নেওয়ার জন্য অনুরোধ জানাচ্ছি। পুরস্কার গ্রহণ করছেন শাহ সেকান্দার তুহিন। সবাই একটু হাততালি। দ্বিতীয় হয়েছেন মোহাম্মদ আলী
মিতুল। দ্বিতীয়
পুরস্কার নেবেন হানিফ স্যারের কাছ থেকে। দ্বিতীয় পুরস্কার সবাই একটা হাততালি। ফার্স্ট পুরস্কার গ্রহণ করবেন আমাদের ডিরেক্টর স্যার প্রফেসর ডক্টর মোহাম্মদ হাসান জাফর স্যারের কাছ থেকে ডক্টর বিজয় সেন, বিনয় সেন। এবং পরিচয়টা দিবেন, আপনি পরিচয়টা দিন। হ্যাঁ, পুরস্কার গ্রহণের পর সময় কম তো।
আচ্ছা ঠিক আছে,
ধন্যবাদ।
আসসালামু আলাইকুম, আমি ডাক্তার বিনয় সেন, আমি সিলেট মেডিকেল কলেজে ফেসবি রেসিডেন্ট হিসেবে আছি।
ওকে,
আসসালামু আলাইকুম।
ধন্যবাদ। পরবর্তী সেশনে অংশগ্রহণের জন্য ধন্যবাদ জানাচ্ছি। আসেন এদিকে আসেন।
একটু
Thank you for exciting quiz. Now we are moving on to the next exciting part of the program.
আমি ডক্টর মোহাম্মদ আলী মিতুল, সহকারী রেজিস্ট্রার হিসেবে কর্মরত আছি জাতীয় নাক্কান কলা ইনস্টিটিউটে।
আসসালামু আলাইকুম, আমি ডক্টর শাহ সেকান্দার তুহিন, কাজ করছি জুনিয়র কনসালটেন্ট হিসেবে শহীদ সোহরাওয়ার্দী মেডিকেল কলেজ।
থ্যাংক ইউ।
ধন্যবাদ সবাইকে। পরবর্তী সেশনে অংশগ্রহণ করার জন্য আমন্ত্রণ জানিয়ে আজকের প্রোগ্রাম শেষ করছি। ধন্যবাদ।
Thank you and congratulations to all the winners of the quiz session. Now we are moving to the